Okay, moving on. I'm really glad to present the next talk. Dr. Mihai Avram. He's a neuroscientist and psychologist who works in the Department of Psychiatry and Psychotherapy at the Schleswig-Holstein University Hospital and the University of Lübeck. Today he will present some very interesting data of the impact that LSD can have on neuroplasticity and the so-called fractional anisotropy of the brain in patients with major depression. So, yeah.
Introduction. I'm going to present you, I think, some very interesting results today of a study. These results indicate that medium to high doses of LSD actually induce structural changes in the brain, and that these structural changes are related to therapeutic outcome. I'll dive right in. So major depression is a very prevalent psychiatric disorder. Unfortunately, our current treatment options are somewhat limited in the sense that around a third of the patients don't really get better. Due to this, there's an ongoing search for alternative treatment options, and psychedelics have recently emerged as a apparently viable alternative. And there are several studies that have shown that psychedelics are or have antidepressant effects which are stable and long-lasting. Most of these studies have been done with psilocybin, but other compounds have also been investigated, and the effects appear similar. Question is, what drives these antidepressant effects? And one possibility is an increase in neuroplasticity. Neuroplasticity reflecting here structural and functional changes that reconfigure the brain. I think it's very important to understand that these changes do not occur in a vacuum. There's an interplay between the brain and the environment, between internal and external cues that drives this rewiring. You can see here a couple of examples of structural neuroplasticity like neurogenesis, dendritogenesis, or for functional neuroplasticity, dendritogenesis. So of course, one question that we can pose now is there any evidence that current treatment options increase neuroplasticity? And the short answer is yes. Both traditional antidepressants as well as rapid-acting antidepressants, such as ketamine, have been shown not only to reduce MDD symptoms, but they also increase or promote neuroplasticity at both molecular and cellular levels. The problem is that most of the studies that investigated these effects have been done in vitro or in animals in vivo. And it's not so easy to investigate this in humans in vivo, but I think neuroimaging does offer such an opportunity. In this framework, neuroplasticity would reflect lasting or stable changes in structure, and we can measure that at a macroscopic level, so for instance, gray matter volume, or at the microstructure level, changes in white matter. And we can also look at function, in this case, functional connectivity. And basically, all of these changes are thought to result from cellular neuroplasticity. In the following slides, I will focus on white matter, microstructure changes. How can we measure this? There is an MRI method, diffusion tensor imaging, which actually allows for the quantification of, or images, the diffusion of water molecules in the brain. And the idea behind this is that the white matter microstructure kind of offers a blueprint for the diffusion of the water, so that there's a preferential direction for water molecules in the brain, for instance, following the white matter fibers. What you can see here on the left side is a T1 weighted image, and the white matter appears in light gray. Here in the middle, you see an image of so-called fractional anisotropy. This is a measure we will talk about. What you see is that the white matter tracts are being highlighted. And on the right side, you see this also colored. The colors actually reflect the direction of diffusion. The direction and the amount of diffusion together build a so-called tensor. This is a mathematical concept. And it actually reflects an ellipsoid with direction. So if water molecules are free to diffuse, you will have an isotropic tensor because there's no restriction. And this will be defined by 3 eigenvalues of equal length. However, if we think about these white matter tracts offering this blueprint for the diffusion, then there will be a direction. And this direction will be seen in a longer eigenvalue, reflecting anisotropy in this case. So this is what we would expect in white matter tracts. We will focus on 2 DTI measures today, fractional anisotropy and mean diffusivity. Fractional anisotropy reflects a relative difference between the largest eigenvalue as compared to the others. It's a summary measure of microstructural changes. I'll talk about this more. It has values between 0 and 1, with 1 reflecting anisotropy. Important to mention that higher values are seen in regions with dense axonal packing and mature cells. Lower values are seen in regions with axonal degeneration and demyelination. Mean diffusivity reflects the mean of the 3 eigenvalues. You can see an image here on the right. So it reflects the average mobility of water molecules, and basically the increase or decrease in values is exactly the opposite as for FA. So first question that we should ask ourselves here is, are these measures changed in depression? Short answer is yes. This is just one example. Larger study that investigated both adolescents and adults with major depression. For adolescents, they found both changes in MDD and FA, and here you see an increase in MD, so this is just for adolescents. And on the top, we see reductions in FA, so in fractional anisotropy, across adolescents and adults. Now, importantly, in adults, FA was decreased in 16 out of 25 regions, so these are widespread effects. It's not a regional thing. Also, I think a nice aspect of this study was that around 300 patients, adult patients, were not medicated, so were medication non-users, and they had even lower FA values than the others. This may suggest that even current treatment options normalize fractional anisotropy. Is there evidence for that? Yes and no. There are some clinical trials that investigated the effects of antidepressants on DTI measures, FA and MD. Some of them did find effects. For instance, decreased MD even 1 hour later. Some of them did not find any effects, even after an 8-week trial. The problem is also how these studies were conducted. If we look at other treatment options, there is evidence that both repetitive transcranial magnetic stimulation and electroconvulsive therapy do increase FA. ECT also decreases MD. And maybe more closer to our field, there is evidence that ketamine increases FA even a couple of hours after infusion. Now we know that ketamine and psychedelics share some neuroplastic effects. Here are some findings for structural changes indicating neuroplasticity after psychedelics, spinogenesis, increased dendritic branches, and so on. Functional changes like increased frequency and amplitude of spontaneous excitatory postsynaptic currents. These findings are derived, as I mentioned before, from in vitro studies and in vivo animal studies. The mechanism behind these antidepressant effects I thought would be related to the TORC-B brain-derived neurotropic factor pathway. This is partly overlapping with the antidepressants and rapid-active antidepressants. More debated is the effect of the 2A serotonin receptor. Evidence in humans is really scarce. So there's this one study that was mentioned in the morning as well from Dawes, in which long-lasting changes in functional connectivity have been observed. Here, decreased brain modularity, so basically an increase in global integration even 3 weeks after psilocybin. As far as I am aware, there is no study that has shown structural changes that are long-lasting after psychedelics. The study that I'm going to talk about today is derived from a larger clinical trial which was conducted in Basel. Here, 61 patients with MDD were randomly assigned to one of two groups. One group received medium to high doses of LSD. The other one received 2 low doses. There were 4 weeks between the interventions. The endpoint was changes in the inventory of depressive symptoms or symptomatology, clinician rated at 2, 6, and 12 weeks after the second intervention. Patients were all adults. They had depression fulfilling the DSM-5 criteria, as well as some other criteria, so that very severe cases were excluded. Now, I was not directly involved in this trial, but I think that the results of it are very interesting. So I reached out to the colleagues in Basel and asked for a summary slide of their results, which you can see here. So if you have any questions about this, please contact Felix Müller, or maybe Matthias can also help. So what you see here is basically the duration of the trial. The baseline was at 2 weeks. 1 week afterwards, the patients in both groups received the first dose of LSD. 2 weeks after that, there was a first clinical evaluation, so at week 5. 2 weeks after that, the patients received the second dose. 2 weeks after that, at week 9, this was the primary outcome, so another clinical evaluation here. And there were 2 follow-up sessions. What you can see at week 9 was that the patients in the high-dose group had greater numerical decrease in depressive symptoms, and then this decrease was significant. However, this significance turned into a trend when adjusting for covariates of no interest, and the main culprit here was the difference in IDSC at baseline. Put differently, the patients in the high-dose group were more ill than the patients in the low-dose group, and this had an effect on the group difference. However, in time, the difference between the groups got even stronger, so the effect remained significant. Also important to mention that this effect was mainly replicated, especially in the later follow-up sessions with other clinical scales. Now, regarding the current study with DTI, from the 61 patients, 38 had viable DTA data. Of these, 35 had very good DTA data and were included in the study, 17 in the low dose, 18 in the high dose group. Important to mention, as for the main clinical trial, the patients in the high dose group were more ill at baseline. Data was processed with several FSL packages. FA and MD were quantified with the tract-based spatial statistics package from FSL. Regarding the statistical analysis, we first computed a model, two-way mixed effect ANOVA with two groups, 2 levels per subject, reflecting the pre-intervention scan and the post-intervention scan, so after both LSD doses. There were 2 main outcomes. The main effect of intervention, so this was a cross group, and in this case not so interesting for us. And the second outcome was the group by time interaction. So this indicates that between the 2 doses, something happened in one group that was significantly different from the other group. In case this was significant, we computed a second model. First, we subtracted the pre-scan from the post-scan, and we computed a 2-sample t-test on this difference. In case this was significant, we then masked the regions that were different between the 2 groups, extracted the values, and correlated them with clinical scores, IDSC, and for control BDI. We did not find any group by time interaction for MD. We did find a group by time interaction for FA. What you can see here in green is basically just a skeletonized FA mask. What you can see, this blob in orange and yellow, these are basically the regions that showed a group by time interaction. And this was significant even after controlling for multiple testing. So we then computed a 2-sample t-test between the groups on FA. And indeed, we found in the same regions, not surprising, that patients in the high-dose group had higher FA values than those in the lower group. The regions involved were the internal and external capsule, the sagittal stratum, and the fornix stria terminalis. So in the last phase, we extracted, or we masked these regions. We extracted the values from the post-intervention scans, and then we computed correlations with the clinical scores. What you can see on this slide is basically a very specific effect. So there were associations between the decrease in depression and increase in FA, but only for the high-dose group. And this effect got stronger with time. So what you have is basically the IDSC adjusted to baseline at week 9, 13, and 19. And for week 13 and 19, the effect was significant even when adjusting for age and sex. And the results were very similar for BDI with one exception. At week 13, the result was not significant. There was only a trend. When adjusting for age and sex, the p-value was smaller but did not reach significance. So what does this all mean? Well, our first main finding indicates that 2 medium to high doses of LSD increase FA more than 2 low doses. The regions in which we found FA to be increased are relevant for MDD. They have all been reported to have lower FA in MDD. And importantly, 3 out of the 4 regions were reported by the Velsen study to have even lower FA values in the untreated patients. So this suggests that these regions are relevant for MDD treatment outcome. Now, I'm not going to go into detail what every region does, but I will say that several of the regions implicate the interplay between the cortex and subcortical areas. Here, I would like to highlight the role of the thalamus, which is involved in 2 of them, because we know that the thalamus plays a highly relevant role in the acute effect of psychedelics. So this was very nice to see that it's relevant also on the structural level and that the effect is long-lasting. The functions related to these structures range from sensory motor processing to cognitive functioning, but also, especially for the last part here, are related to the limbic system, so emotional processing. All of these are impaired in patients with MDD. So it's nice to see that FA increases here. The second main finding was the specific and consistent relationship between increased FA and the clinical scores. This was specific for the high dose group. So now the question is, how do we interpret all this? Is it an increase in myelin, for instance? This is possible. We know that there are oligodendrocytes in the adult brain, that they remodel myelin sheets. Again, this doesn't happen in a vacuum. It happens in an interplay, right, between internal or external cues and the brain. Internal cues could be something like external activity, and this is definitely affected by LSD. Here you can see such a model, so around 10 to 15 glial cells in the adult brain are so-called oligodendrocyte precursor cells. This proliferate, differentiate into oligodendrocytes, and then attach to axons. You see active axons in red and inactive or less active in blue. And within a couple of hours, there's already a pattern, and the oligodendrocytes start creating these myelin sheets. And then, according to what's happening with the axons, these myelin sheets kind of stabilize in time. And in weeks to months, we have more or less a stable pattern. So this is something that is possible following LSD, and it could be a viable interpretation of the data that we see here. However, what is FA? FA is a difficult measure to interpret. While the majority of studies do report an increase in FA to correlate with an increase in a certain function, the opposite also holds. So some studies find that an increase in a certain function is actually linked to a decrease in FA. How is this possible? Well, the problem is that if certain axons, for instance, cross one another, there will be a decrease in FA. So it's possible that the myelin sheet is growing on two axons that are very close to one another. There you would have a crossing, the signal would decrease. This is then problematic because there is no straightforward relationship between the measure and the underlying architecture or tissue properties. We also know that FA is modulated by several features, and we cannot pinpoint the exact cellular mechanism behind it, or mechanisms. What we can say is that the measure captures the sum of all white matter microstructural changes. And this is also the conclusion of this talk, that there are microstructural changes with 2 medium to high doses of LSD, maybe also with the low doses, but we do not have a placebo condition here to control for this. We definitely see, however, a difference between the two groups, and this change in microstructure is relevant for treatment outcome. I would like to thank all my colleagues and collaborators from Lübeck, Stefan and the team, Aurore, who is a DTI expert from Munich, and Felix and Matthias, who actually acquired all this data and were nice enough to share it with us. And thank you for your attention.
Thank you. Yeah, thank you. Congratulations. These are some really great findings, like especially the correlation with the outcome. It's really fascinating. Are there any? Oh yeah, there are questions in the room. So maybe we start there.
Hello. I was wondering why it can be that the trend or the correlation between outcome and change in fractional anisotropy is different or opposite regarding the high and low dose. So if you actually were to assume that the neuroplasticity is the driving factor, why could it be the opposite direction for the low dose group?
I mean, one is significant and one is not. It's not really the opposite. I would say it's the opposite direction if it would be significant, but for the low dose, the relationships are not significant. So it doesn't really count then, does it?
Would you not still expect for the people with a lower or with the change in fractional anisotropy in the low dose, they would still react in an antidepressant way, if that's the causal factor?
I think they did Partially, I think it's clear that there is an effect of the low dose, but in the brain, in comparison between the two groups, I would say that the low dose did not reach or did not appear to reach a certain threshold. I'm not saying that there are no neuroplasticity effects. There could be, but apparently they are not strong enough, and they were also not strong enough to see significant association between them or the right direction between them. It could be also other factors that we did not look at yet. Right? So this is now just white matter microstructure. I'm actually very surprised that no one looked at gray matter. I don't understand why. I think it's a very easy analysis. We are now looking into this as well.
Hi, thank you for your talk. I have two questions. The first one is, do you have like blood dosage of LSD so you can maybe compare with a continuous variable rather than just a binary variable according to the group, and maybe evidence some linear relationship that could support further your hypothesis? And my second question is about the subjective effects. What do you think about the relationship between subjective effects and increase in FA?
So regarding the first question, yes, I think there is some blood data, but I have not looked into that yet. I also don't have it. I only looked at BDNF. I think this was serum, but I did not find any significant relationship there. Regarding the second one, so clearly there is something that Matthias showed in the morning, a relationship between the subjective effects and the treatment outcome. I checked also to see if there's a relationship with the FA, but I did not find a relationship.
Are the areas that you find affected with LSD the same ones that are also affected by antidepressants in the other studies that report contradictory results, but are they the same areas or is...
Yes.
Yeah? Ah, okay. So neuroplasticity is the same in both cases in that case. Ah,
there appears to be an overlap, yes.
Any more questions? So maybe from my side, this is the first study I've seen to fractional anisotropy in psychedelics. Are you aware of any findings for this concerning psilocybin or one dose of LSD or?
No, actually I was surprised to see on David's slides before something mentioning DTI, but I think it was just planned, so I'm not aware of any study that looked into this yet. It would be nice to see if these findings are actually replicatable. Okay, I'm not finding the right word now. With other compounds, yeah.
Okay, great. So exciting. Okay, one last question maybe, and then we move on.
More of a control. What about non-pharmacological ways of inducing neuroplasticity, like patients who started to do extreme amounts of sport? Is it also the same areas that are affected or not?
So the question would be whether non-pharmacological treatment options for depression
or anything, like is neuroplasticity or are changes in FA in these areas something that always happens when you increase neuroplasticity independent of how you do it? Or is it something specific to the therapy?
No. So I think it kind of depends. So you can also increase neuroplasticity by starting to joggle, right? And this would increase FA, but in different areas. It's not the same areas. That's why I said, or that's why I think that these areas might be relevant for MDD in particular, because these other findings that have now nothing to do with psychedelics also find changes in these measures here in these regions, right, in these white matter bundles.
Thank you.
Okay, thank you so much, Mihai.
Thank you.